At this time, I'd like to introduce you to our speaker, Lance Keeler. Lance has over 20 years of healthcare experience and is the president for a rural healthcare consulting company specializing in critical access hospital operations, hospital administration, physician practice management, rural health clinics, market analysis, and radiation oncology management. Lance has most recently served as the administrator for a critical access hospital and regional cancer treatment center in Texas. Lance has served on many state and national committees and boards, including the Texas Organization of Rural and Community Hospitals, the Northwest Texas Hospital Association, and the Texas Hospital Association's Health Share, as well as past chairman of the THA Rural Constituency Council. On a national level, Lance has served as the Hospital and Health Systems Constituency Group Chairman for the National Rural Health Association, as well as a board member and chair of the membership committee. He served as NRHA president in 2012. Now I will turn it over to Lance.
Great. Thank you, Kim. I really appreciate the opportunity to spend the next few minutes with everyone on the call today. Obviously, when we start talking about leadership, succession planning, and transitions, it's really issues that none of us want to face. But the reality of it is that we're all going to have to address them as we move forward as healthcare changes. And so what I'd like to do today is offer you some suggestions, maybe some pointers, some hints. I have quite a few slides, but I'll go through them fairly quickly due to the fact that I would love for this webinar to be as interactive as possible. As Kim mentioned, we're very open to your questions, and so please do not hesitate to send her a chat asking questions, and we can answer those as we go through the seminar. But I want to thank you for taking time out of your schedule to be on the call today, because I know you're all very busy. I also want to thank Wayne Hillerstead. Wayne was really my co-conspirator in this presentation today. Unfortunately, Wayne was not able to be here. He has some family issues that he's dealing with, but Wayne has a tremendous amount of administrative experience and helped me with this presentation, and so I'm very grateful to him. I'm also grateful to Kim and to the National Rural Health Resource Center for allowing me to spend a few minutes with you today. So with that, we will get started. Well, as we all know, healthcare is changing. It's changing in a lot of ways, and the cartoon on your slide says part of the problem is the number of employees who think they know the solution. And I think that we can hopefully laugh at that, because in all of our organizations, we do think that we know the answers to the solutions most of the time. But as leaders, we have to kind of facilitate through that and really find out where we need to be at the end of the day. We're dealing with healthcare reform. We're dealing with changes in healthcare. If you're from a clinic background, you have issues facing you. If you're from a hospital background, obviously you have issues facing you, going from volume to value, reimbursement issues, and things like that. So regardless of where you are in the healthcare industry, healthcare is changing. We've got healthcare reform. We have access to care issues. We have this whole issue of trying to get a population to be healthy and not just take care of illness. And it's almost like an organizational chart. Where do we go and what is connected, and how do we handle it? Well, according to the ACHE, the financial challenges again ranked #1 on the list of hospital CEOs' top concerns for 2015. And the rise in the rank of personnel shortages as the top concern for hospital CEOs from 10th ranked concern last year to 4th is a huge change. Obviously, transition transition is happening in our organizations, not only in the C-suite level, not only with our physicians and our providers, but also with our management level directors and our staff. And so this presentation today will not just be focused on CEO transition. It will also focus on manager director level transitions as well. But we just need to understand that as we move forward with a changing healthcare environment, we are going to continue to see changes in our healthcare staffing patterns on all levels. Don Berwick, who used to be a CMS, said the best way to get a good idea is to get a lot of ideas. There's a right thing to do with regard to quality of care. Improve it. If it takes courage, so be it. The reason I included this today is that we can't lose sight of the reason that we're all here. We're all here to take care of patients and to improve the quality of care to the patients that we serve. Obviously, when we have staffing changes, that does affect our quality of care. You can determine that on different levels. But what we have to figure out is how do we get a handle on transition, knowing that it's going to happen, and how do we deal with it? So our learning objectives today is we're going to discuss succession planning, how the industry transition is transitioning to a value-based system. We want to talk about succession planning, about leadership's role, about how leadership transitions affect the organizations, how do leaders handle succession planning, and then hopefully what you're going to get out of this is some practical methods for succession planning for your organization or your department. Kelly Gooch with Becker's, this is a March 11th, 2016 article. She did an entire article on this, but the title of it was Hospital CEO Turnover Rate in 2015 among the highest reported in 20 years. At the bottom of the slide, you'll see where she writes, the high level of change taking place in hospital C-suites underscores the importance of organizations having well-developed succession plans to manage changes in senior leadership roles to ensure success in today's environment. And I think she's right on point, and you can tell from the date this is current information. This isn't something from an article 20 years ago. These are issues that folks are dealing with today. Whenever we hire people, obviously we're wanting what's on the screen. We want that dream job, whether it's for us, whether it's for the people we're hiring. Everybody is looking for the dream job. Now, in reality, if you do what you're passionate about, that may be your dream job. But we have a changing culture. We have a generation that is coming into our marketplace that has a different perception than folks that have been in the industry for a long period of time. And I think we're seeing that. The expectations are different, and it doesn't matter if you're referring to a physician, an administrator, a department manager, or a staff member. The expectations for the younger folks coming into our organizations is completely different than it was even 5 or 10 years ago. So what is succession planning? What's the deliberate, organized effort to identify and prepare a process for the replacement of people when they leave? It involves predetermined planning, which many don't do. For the CEO position, it should be supported and engaged by your governance structure, whatever that is. And the succession planning involves more than just the C-suite, as I mentioned earlier. It does need to include the manager, director level, and we will get to that in just a few minutes. Succession planning involves two parts. One, when the position is vacated, that can be a voluntary resignation, that can be a retirement, or it can be involuntary from a termination standpoint. But when there's a planned departure, succession planning needs to play a role in that for the health of the organization. Now, I hope you get a chuckle out of the cartoon that's on there, because denial and reality are two different things, obviously. Sometimes when we're talking about succession planning and transition, we're in denial because we don't want to do it, we don't want to deal with it, and so we go round and round in a circle because we're afraid that the reality of the transition of succession planning will do like in the cartoon and send us off the cliff, which obviously none of us want to do. But there are pitfalls in succession planning. I won't go into a lot of detail on these, but obviously one is a lack of a clear strategic plan. Resources need to be spent, but they need to be spent with a clear vision of the organization's leadership needs, and succession planning needs to be part of the strategic plan. The absence of a contingency plan is another pitfall for succession planning. Unfortunately, all too often, a staff member, whether that be a manager, director, or a C-suite level person, will leave the organization involuntarily or voluntarily, and we don't have a plan. What are we going to do? So hopefully today, a couple of the things that you'll get out of this presentation is just the fact that we need to have a plan in place on some level to allow us to plan for succession. And then the third thing that really happens, and this is much more so probably on a board level for a CEO than it is for anyone else, maybe a chief medical officer. But all too often there's a lack of board approval or board involvement in the succession planning. Now, we're going to go into some of the reasons for that, but it is vitally important that especially on the board level, they are involved in the succession planning. I do quite a bit of work with hospital boards, working with governance, and I always relate to the board that the board really has a couple of basic fiduciary responsibilities. Number one, it's for the strategic planning of the organization. Number two, it is for the approval of the budget process, both operational and capital budget. And then I say this a little bit tongue-in-cheek, but the other role of the board is hiring and firing of the CEO. Now, unfortunately, there are a lot of organizations out there that the board gets involved in a lot of other positions outside of the C-suite. But really, in most organizations, the board needs to be involved, especially in the C-suite decisions, because that is going to guide the organization through strategic planning and transition. Now, as we move forward with this, I want you to understand that succession planning is not comfortable. It can be difficult, and there is frustration and growing pains with it because there is not a perfect process. I say that because each organization has a different culture, they have different politics, and all of these things have to be taken into consideration as you move forward with setting up succession planning. Now, when we have succession planning, or if we don't, sometimes it's easier. As you can see in the cartoon in front of you, the line for the comforting lies is very long, but the unpleasant truth doesn't have anybody in front of it. This is kind of like the reality in the denial cartoon that we had earlier, but the reality of it is it's not always pleasant setting up succession planning, because you have to have conversations about what if. And if you're the CEO, a lot of times you don't want to have that conversation with the board because you don't want them to think you're leaving. If you're a board member, you don't want to have that conversation with the CEO because you don't want them to think that you're trying to run them off. So we kind of go around in this circle of we need succession planning, but we don't really know how to engage in it. This is the last part of that article from Kelly Gooch out of Becker's, and I just thought that it was important. Some of the states that are listed on there relate to the high CEO turnover. And the reason I put this is because if these rates don't alarm you, they should. You know, I'm outside of Kansas City in Lee Summit on the Missouri side, and for Missouri in 2015 to have a 30% CEO turnover rate in their hospitals, that's really concerning. Obviously, there are other states that have different turnover rates, and there's different reasons for that. But any time you have almost a 1 in 3 turnover rate with your hospitals, that's going to directly affect your continuity of care and the continuity of the direction of the organization. There's a lot of changes in healthcare. The average tenure for a CEO back in 2010, according to ACHE, was 4.6 years. Just 3 years later, Becker's came out and said that the average tenure for a CEO was 3.5 years. The factors included an aging workforce, changes in healthcare regulations, and mergers, acquisitions, and closures. And as I just mentioned, the CEO is not the only leadership position that's at risk during CEO turnover. The average hospital CEO tenure is under 3.5 years. 56%, according to Becker's in 2013, 56% of CEO turnovers were involuntary, which means that the CEO was probably terminated. When a CEO is hired, almost half of the CFOs, COOs, and Chief Information Officers are fired within 9 months, and even more concerning within 2 months of a new CEO appointment, 87% of CMOs are replaced. I added this slide because I think this is so germane to our conversation that as we have conversations about moving from volume to value, if our chief medical officers are being transitioned out every time we have a new CEO, then we have some serious issues regarding the continuity of care for our patients. Going on with this, 89% of the people in this survey in 2013 involved in the hiring process believed that a broad area of business expertise was beneficial in a hospital CEO position, and 94% of new CEOs without the healthcare sector experience believe that extensive healthcare knowledge is not necessary to replace senior management positions. This almost goes back to the Disney concept that you don't have to have expertise in a particular area to manage a company. Obviously, we can debate this all day long as to whether or not we support it, but the information is out there. At the bottom of this, what's interesting to me is that most new CEO candidates come from venture capital, private equity, industry backgrounds, 42% of those, and then 40% were finance and accounting backgrounds. Now, down in Texas, a couple of years ago, they did a critical access hospital project regarding CEO leadership, and they did an evaluation of critical access hospital administrators, and half of the respondents felt that they inherited healthcare organizations that were in a weak financial position. And obviously, when you see the information out of North Carolina and different organizations that do research, you know that a lot of the rural hospitals are struggling and are in a weak financial position. So that wasn't as big of a surprise. But what did surprise me on this is that board relationships were ranked the #1 priority for the CEO, followed by organizational commitment. So when we go back to our earlier slides regarding the lack of board involvement in succession planning, we have almost a conflicted story that we need to pull all the pieces together so that it reads properly. The critical factors for this study in CEO retention, it stated that the intent to leave was not based primarily on the financial performance and geographic location. It was based on good working relationships with the hospital board, and that was important. The governing board needed to be reliable, supportive, accommodating, and dependable. And they liked boards that did not have high turnover rates. Obviously, quality and safety of the critical access hospital and all hospitals are affected by CEO turnover, and as we just saw, the chief medical officer turnover as well. Thomas Dolan, who is the president and CEO of ACHE back in 2013, said, "Now more than ever, hospitals must ensure they have the appropriate succession plans in place to avert any potential negative impact of leadership changes. Hospital boards and CEOs must work together to achieve this." And again, this reiterates what we've been talking about the last few minutes. there are leadership challenges that are out there in our C-suite and to a point with our managers and directors. In a lot of the hospitals, there are severe limitations to capital necessary for the infrastructure and for provider recruitment in our hospitals. There's an increased burden of remaining current with volume to value changes, quality outcome reporting, changes in payment methodology, and all of these things for CEOs are really just driving a lot of regulatory friction and just stress overload for the CEOs, which directly ties into part of the turnover rate. They're also having continued difficulty with the recruitment of providers, increased competition from other hospitals and physician providers for limited revenue opportunities. Other challenges include the requirement that your information technology is on par with large hospital systems. And I'll take just a second here to say, as an industry in rural healthcare, we're going to go through some transitions over the next few years that are going to potentially be adversely impacting our hospitals financially. With the incentive money, the EMR incentive money going away, a lot of the hospitals have used that to help financially stabilize their hospital. And so my concern is that as we move forward, our information technology does have to be on par with the large hospital systems, but the capital outlay that is going to be required to maintain that for a lot of our smaller rural hospitals may be catastrophic. The other leadership challenge that they listed in this study was that hospital governance members don't have sophisticated understanding of hospital strategies, finances, and operations. And if a CEO has ever, or a CFO has ever tried to explain a cost-based reimbursement methodology to a new board member, I think you understand what they're dealing with here as part of the challenges. So where are we headed? I think as leaders, we feel like this guy, we're getting squeezed between two rocks, but we're trying to hold them up and be the superhero, and it's getting harder and harder for us to maintain that equilibrium between good succession planning, organizational change, and strategic planning. But our future of healthcare is based on value, and I believe this is probably one of Terry Hill's slides that he allowed me to use, but where we're going is to a value-based system, not a volume-based system, and it's going to be our quality and our service over our cost, equating to our patient value. And as there is more and more information online regarding patient information, access to different technologies and services, our patients are going to become more and more involved in the delivery of their health care. So why is succession planning important? Well, first and foremost, it provides long-term continuity and stabilization for the organization. It reduces chaos, confusion, apprehension during turnover, and it can provide stability during what can be a difficult time. The positions that should be considered for succession planning should be all of your C-suite positions, plus your HR manager if that's not a C-suite position, and in my opinion, your director manager level positions as well. There are recruiting firms out there that specialize in director manager level recruitment, and I can tell you that the turnover in those areas is just as high as it is in the C-suite in many organizations. So I think it would be a disservice if we had a conversation today about succession planning and did not include the director-manager level role. So who should do the succession planning? Well, for the CEO, it should be a committee made up of the CEO and select board members. For other positions, if it's a manager-director level, it really needs to be driven by the CEO or their designee, if that's human resources, or the chief operating officer, whoever that might be. But the CEO needs to be involved in both areas. When you're talking about the manager-director level positions, which ones should be considered? Well, in my opinion, all of them should be considered, but specifically laboratory, diagnostic imaging, perioperative managers, pharmacy, IT managers, all of these positions that can be hard to recruit for in rural areas should be part of your succession planning. So what's the current state of succession planning in hospitals? Well, a recent article that was geared toward larger facilities that had a lot of resources said that less than 50% of those hospitals have succession plans. That leads to the question of why. Well, regardless of the size of the organizations, most CEOs either haven't thought about it or they don't know where to begin. And just the same, the boards don't think about it, so they don't raise it as an issue. So this is not just the small rural hospitals that are not planning for succession. It's also the larger hospitals as well that oftentimes have the financial resources to move forward and to help with this process. Why are they afraid? Well, they're afraid, as we talked about earlier, because the CEO doesn't want to raise it to the board, and the board doesn't want to raise it to the CEO, and the CEO doesn't want to raise it to the department managers, because we don't want anybody to be paranoid that there's a change. But I think it goes back to the culture of the organization. Now, there are some that, due to a lack of resources, they don't do it. For some hospitals and some leadership, it's not a priority. And obviously, if you're a new CEO going into an organization, you do not want to start off by talking to your board about succession planning. Now, you need to, obviously, but it's a very uncomfortable situation to be put into. So what would you do in your organization if the CEO suddenly departed? Panic? Would we appoint a CFO or a chief nursing officer as an interim? Would we appoint a team leadership committee? Would we find a senior manager who says yes? In some organizations I've seen, the chairman of the board becomes the acting CEO or maybe another board member. Sometimes you get a retired CEO that will come back and play that role. And as the CEOs change, that's kind of the process that we've historically gone through. You can do that, or you can develop a plan of succession with the focus being on a planned approach, not finding a person to fill the slot. All too often, we want to find a person to fill a slot and not find the right person to lead our organization. And almost without fail, that ends up backfiring on us for a whole host of reasons. The CEO should develop a draft of materials and tools for the board. The board should be involved. And normally the succession plan should be reviewed annually to ensure the appropriateness of it. The other thing by reviewing it annually that this does is that it keeps the conversation out in front of the CEO, their managers, and the CEO and the board. And if you can keep it as an ongoing topic, it takes away a lot of the awkwardness of talking about succession planning. So first, as a preliminary step, what would happen in succession planning is the CEO would get with the board chairman, have a conversation and say, Bill, we need to develop a succession plan. I'm not going anywhere. I don't want rumors started, but we need to start that conversation, and I'd like for that to become part of the board discussion. And then at that point, the CEO and the board chairman talk about it, and they come up with a plan as to what are next steps. That needs to take into account the hospital's culture, the local politics, and the makeup of the board. And so once that's done, it goes to the board. Normally, the board chairman will appoint a committee. The CEO or the board chairman can lead the discussion, but the board education session should end with a committee being set up that could handle succession planning and put together a plan for succession planning. It should be a formally established committee. The chairman of the board should appoint someone to chair this committee, and the CEO should be the staff person in charge with providing the necessary tools and resources for the committee to do this function. The board of directors process may include a national search firm. It may use independent consultants during this process. It may identify internal candidates to promote from within. But the board discussions at each step are essential, and the board committee needs to meet on an ongoing basis once you're in the process of replacing a CEO or a senior leader. Sometimes the boards expand the committees, and other members of the committee may include physicians, it may include community members, it may include volunteers. And in some instances, I've even seen where select department managers are part of this process as well, depending on their role and tenure in the organization. Job descriptions are one of the things that all of our organizations should have and should keep up to date, but you would be surprised at how many organizations I go into that the job descriptions have not been reviewed in 10 years or 15 years. When you think about it from a C-suite position, you absolutely want your CEO's job description to be updated because things are changing. A contract for a CEO 15 years ago would probably not be appropriate, and the job description would probably not be appropriate for a CEO today. 15 years ago, we were talking about inpatient census and how to grow that. Today, we're talking about outpatient volume and how do we expand our care to meet the population health requirements of our community and our region. So things are completely different, and job descriptions should be updated and kept current. So if you don't do that, I would suggest that. The tools that the committee will need is they'll need the job description, they'll need a list of the competencies so that the committee can rank those. They need to have CEO personality characteristics that the committee can rank. There's a checklist of elements that could be included in the plan. And then obviously there should be a CEO evaluation tool that can be part of this process as the new CEO is hired, so that they will know going forward that annually they will be evaluated by the board to make sure that they're meeting the requirements in the job description for the position and to meet the requirements for the organization. Now, your checklist of your elements may include a communication process. You've got to make sure that when you have transition that you're communicating with your physicians, your employees. If it's a C-suite level or a chief medical officer, you need to communicate with the state health department in many states. There are constituency groups out there. And then there's the public. You could also, for this planning checklist, develop sample memos for the staff, even developing media press releases if appropriate, so that if there is a unplanned departure, there is a standard response from the hospital that can go out to the community. I've also seen in some hospitals where they actually script do scripting for the board members and for the C-suite teams so that everyone is saying the same message and everyone is on the same page. In smaller organizations, a lot of times it's not necessary, but it's still good to have as part of the planning checklist. If you're going to use an interim during this process, how will the interim CEO be chosen? Is it an internal person? Are you going to do external placement with the search firm? What are going to be the duties of the internal interim or the interim person? Do you need additional board approval for an interim? And then when you start talking about the permanent CEO, you're going to be looking at possibly internal candidates. Are you going to advertise maybe in the local or regional newspaper? Are you going to engage a search firm? But the resources need to include potential interim staffing firms, search firms. There needs to be a location in the hospital where the board chairman can access the succession planning file, and it also needs to be available for the committee as well, so that in the case there is a transition, everyone knows where to go to get it. Now, I just want to caution you at this point, because succession planning is not going to be something that's going to be accomplished overnight. It does take time. You do need to take your time and not rush through this process. And I would encourage that you use interims as necessary based on your organization's financial position to give the board time and the community to make the right decision. For those of y'all that were able to print out your slides, you might be able to see this, but the cartoon that I put down here in the corner, at the bottom it says, rumor has it that you bailed from your last job. And the guy sitting in front of the CEO with a parachute on that's already gone out. I think that we can laugh about this, but with all the transition that's going on, there are a lot of people bailing out of organizations. And again, going back to a previous slide, we need to make sure that we're not just filling up a position, we're not grabbing the first person that comes along. We're hiring with the intent that this is going to be the leadership of our organization to take us where we need to be long term. This cartoon says that it's time to take the bull by the horns, and that's really what your succession plan is intended to be. That way you don't have to run around, no pun intended, like a chicken with their head cut off, but you do have something that will guide the board through a planning change or a transition when leadership changes take place. Now, when you're recruiting, you have to be realistic that there are recruiting difficulties out there. It can depend on your geographic area. It can depend on your financial situation in your hospital. Search firms can be very expensive regardless of the position that you're recruiting. And so do you have the funds to engage them? If you have multiple applicants, it can be very hard to find the correct fit of your organization. And it can also be hard to kind of process through them just based on your resumes or your CVs without doing further in-depth research on each candidate. But once again, don't rush and make a bad decision, because that's going to affect negatively the organization for years to come. When you talk to outside search firms that are in your organization, this is currently what they're saying, and frequently this is what they uncover when they get in there. Current leadership workload inhibits the mentoring of future leaders. Our current leadership is just so overwhelmed that they don't have time to mentor. The organization's inability to deal with ineffective leaders. I know that Quint Studer always talked about the 8% in our organization, and I'm going to paraphrase, but he basically said that there's 8% in every organization of our staff that don't need to be there. But those are the 8% that take up a high percentage of our time from the standpoint of dealing with issues and problems. The other thing that outside search firms see are inefficient and extended interview processes. This can send the wrong signal to candidates, and oftentimes candidates are looking at multiple positions. So if you do not have a good succession planning process in place, there's a good chance that you may find a candidate that you love and you want to extend an offer to, but if it takes too long, they may go with another organization. And again, this is not just for your C-suite, this is also for your manager, director level positions as well. And then the other thing that outside search firms currently see are salary ranges that lag behind what is currently offered, either in the region or in the state. Nationally, there are organizations that have salary surveys that you can access as an organization, but especially when you're talking about manager, director level, and C-suite, you have to make sure that your compensation package and your benefit package is competitive to allure the best candidates to your organization. If you go with the recruitment firm, you need to understand that there are true recruitment costs. Recruitment of med-surg RNs can range from anywhere from $15,000 to $25,000. Recruitment costs of C-suite can range from $32,000 to $62,000, depending on the salary range for the individual. Most contingency firm fees are ranging from 20 to 30% of the candidate's first year salary. The average search firm guarantees less than 90 days, but there are a few out there that will go a year out on their guarantee for that position. What that guarantee means is that if you recruit somebody in and they're there for less than the contracted amount, then you're not responsible for paying the search firm to do another search to replace that candidate. And that's always something good to have in that contract. And then the other thing that they see is that when you have leadership recruitment issues, there are opportunity costs that are created by vacancies, and they can vary due to staff morale, turnover, the physicians, and it can affect patient satisfaction as well. You should consider interim leadership consultants as a stopgap measure. Usually these folks, these interim leaders, are available within 2 weeks to 3 weeks. They're normally overqualified. There's somebody that will come into your organization that has 20 or 30 or more years of experience. They can be a manager, director, or vice president, a C-suite level. They can provide team assessments. They can develop and help you develop subsequent plans for success. Most assignments are anywhere from 90 to 180 days, even though I have seen interims in organizations for up to a year. They also have the ability to stabilize and advance departments, teams, and facilities. So when you look at interim leadership, there is a cost with that, but in many cases, you will get your money back due to the varied experience that these folks bring into your organization. If you decide to go with a search firm, a good search partner can help you in a lot of ways. They can increase that placement guarantee out to a year. They can expand the candidate pool beyond your local area. They can bring together candidates that are not currently looking in an active search. And you normally will have a primary search consultant to conduct your search. That is your contact person for the organization. And that helps with the transition not only of interviewing the candidates, but that also helps post-placement to make sure that not only you're satisfied with the placement, but that the new hire is satisfied with the placement as well. If you're looking at internal candidates, you need to take into consideration, do these folks have the leadership skills, the abilities to become a leader, specifically a CEO? What is their education level, and what are the skills and abilities that need to be honed in order to go into this? In many smaller organizations, sometimes this is where the politics come into play. You have somebody in a position that's been there for 25 years, and everyone just assumes that they're going to be the next person. This is an opportunity where the board can work to see if this is a good fit for the organization long term, but it's also a double-edged sword because it can put the board in a difficult decision-making process of putting someone in an interim position that may not have all the skills and abilities to handle the organization appropriately. You also have to take into consideration what is their relationship with the board, the physicians, the executive team, the department manager. And if you're fortunate enough that the CEO that's currently there is a planned leave, what is the time frame? Most contracts are calling from anywhere from 60 to 90 days notice, depending on the contract. Sometimes organizations, if they're able to find someone sooner than that, they will work with the incumbent CEO to be there. You also have to take into account that if you're using external candidates and they're in a contract, you're going to have a waiting period there as well. And at the end of the day, what you're wanting to ask internal candidates is, are you ready to be a leader? So if you do have interim candidates, if the interim candidate is not chosen, what's the options at that point? Do they go back to their original position? Is there an exit strategy? What do you normally do with these people from the standpoint of awkwardness? And if someone has the expectation that they're going to be the interim and get the position, and they don't get the position, the board needs to have that thought process, especially on a CEO level. From a CEO standpoint, it's also difficult when you have a smaller department. If you have someone in the department filling in, and you have transition there, is there an unrealistic expectation that this person is going to have the job forever? If not, as part of the plan, the CEO needs to be very clear with this individual that this is just a temporary measure to help the department, or the board needs to be very, very clear with that interim that this is only a temporary position and it will not turn into a long-term position. I love what Richard Branson says. He said, train people well enough so that they can leave, but treat them well enough so they don't want to leave. And as we start thinking about moving from volume to value in our organizations, we're going to have to lead our teams in that methodology, in that mindset. And part of that is really taking our staff and engaging them on a level that they have not